Good morning, everybody. This is the 2021 this MOS conference, which takes its birth today, and the first session starts with none other than Dr. Manoj Sasavde, who is going to talk to us on the clinical utility of ultra wide field imaging. Manoj, can you go ahead, please?
Thank you, madam. Thank you, everyone, for giving me the opportunity to talk on this very useful topic in the Retina practice. Uh, we know that the ultra-wide field is almost 200 degrees wide field photography is seen in a 0.4-second click. It is useful for the professionals like us to detect, diagnose, and treat the retinal diseases and to provide the state-of-the-art image capture and review it periodically. Basic intention of my purchasing this equipment was self-assessment and self-criticism of your own diagnosis. Then counseling to the patients, teaching purposes to the fellows, PGs, and co-workers, as well as to referral doctors, as well as the good documentation. Normally, we know that this is other cameras will give us the only 45-degree wide field, but this Daytona gives you almost 200 degrees. That is 95% of the view is visible on single click, and it gives you the various diagnostic modalities. Particularly, if you are doing a medical retina, then various types of vascular disorders like BREO, CREOs, superiotemporal BREOs, central retinal artery occlusions. These are one-time diagnosis. Am I audible?
We will start with the basics, tunnel pathways.
Yes, sir, you are audible.
Yes. This is you can see that what a wide field image is seen of the superiotemporal BREO. Previously, it was treated, incomplete treatment was done, so the patient was suffering recurrent hemorrhage and new vascularization. So you come to know that how much area is to be covered again. Then this is a superior hemicentral retinal vein occlusion post-treatment and pre-treatment. This is a case of PDR. You see that this is a panoramic view we get before the surgery, and you know the extent of the TRD and the membranes, which is not possible with the other modalities. This is again a PDR case. So the wide extent of the area is visible on ultra-wide field imaging technique. This is a case of pre and post anti-VEGF injection. You can see that this hemorrhage and everything has gone, and you can counsel the patient very well. This is another thing which one would like to document. The post Avastin or post anti-VEGF, you have come across the progression of the TRD, and it is now a surgical case. Then post-treatment, laser treatment, what you have done, you can show it to the patient and you can assess yourself also. If you have ultra-wide field angiography also, then you can do the angiography and see the various types of ischemic areas on the angiography. Here you can see that ocular ischemic area, ocular ischemic syndrome case where the extensive peripheral non-perfusion area is seen. Here also you can see that the extensive number of n number of NVs are visible on ultra-wide field angiography. This is a FUR case where you can see that the treatment is required, more and more treatment is required. And this is a case of PCVA with hemorrhagic PCVA, and post TPA we have taken the photograph, and you can see that the hemorrhage is displacing now. This was a case of Coats disease, and this doctor was thinking that this was a traumatic case, but once we show him that this is not a traumatic, but it is a Coats disease, he is convinced now. There are certain cases where you need one-time diagnosis at least, which are the cases, otherwise the people will keep on shopping. Here it is a case of retinitis pigmentosa. You should show that what is the exact pathology and why he is having night blindness. Same thing that if you have ultra-wide field fundus photography apart along with the autofluorescence, you can see that this is a unhealthy and healthy retinal pigment epithelium. Then here the recurrent CSR cases, chronic CSR cases, you can get a wide view of the pathology. In certain cases like a myopia, choroidal colobomas, high extensive myopias, people need counseling. This is the extensive myopia bilateral. He needs something to be known, or his relatives and progenies also. This is a choroideremia case. Actually, once he sees the patient, then his shopping stops. These are the albinism patients. You can see the extensive panoramic pictures and beautiful pictures. Once they are visible, the patient's counseling is done, relatives counseling is done. This is a case of Modulated nerve fiber. You can see this such types of modulated nerve fibers in a single click is beyond other imaging modalities. Another case is important thing is in ultrawide field imaging is that in trauma cases, basically you need documentation pre-treatment, post-treatment, as well as the medical legal purposes. Here you can see the extensive, yesterday we saw in the morning, the case of blunt trauma by the tennis ball and the extensive commotion retini case. This is another previous case of commotion retina and Berlin's edema. Pre-treatment and post-treatment, you can see the things and patients can be convinced. This is a case of post-traumatic subhyaloid hemorrhage, post-drainage. You can see the sequential photograph you can show, and you can also document and review your own treatments. There are other cases where the retinal detachment cases and trauma cases also. Here you can see the choroiditis clepitoria case. The retinal tear has been seen, retinal and choroidal edema is there. Here retinal dialysis also can be captured in ultrasound, ultrawide field imaging. And this is a case where the foreign body, you can show it to the patient and document it before treatment. This is a case of tumor cases. You can document it very well, and you know the importance of knowing the fundus photography in tumors for the exact mapping of the size and shape. Here, this is a retinoblastoma. We have treated it, and this is almost 10 years we are following this patient. This is a calcium, which is, you can see that it is at extreme periphery. This calcium is because of the retinocytoma. And you can see this is a huge malignant melanoma picture, which is not seen even in many textbooks also. This is possible with ultrawide field imaging. This is a von Hippel-Lindau disease bilateral. You can see that there are multiple angiomas. Here also you can see the dilated feeder vessel and all these things. This is a case of central retinal artery occlusion. In case of COVID, we have got a tremendous usefulness of this technology. You can see that the bilateral endogenous endophthalmitis case, which was documented. This is a case of CME retinitis. It is like a book picture. Pre-treatment and post-treatment, you can see. This is another case of CME retinitis in case of steroid after steroid, giving the steroid in a pars plana vasculitis. This is a case of pan vasculitis in a case of toxoplasma case. Pre and post clindamycin, you can see the sequence to the improvement to the injections. Then in cases of the peripheral retinal lesion, this is a very useful tool. You can see the horseshoe tear, which is treated very well and patient is convinced with the treatment. Then previously we used to draw the many drawings hours together in our fellowship days. Now you can see the horseshoe tear and whole RD is visible in a single click, and you can keep this photograph in OT. Here also you can see the huge picture of retinal detachment, which otherwise is not possible for an operating VR surgeon. Then the patient, if do not listen to you, you can see that this is non-listen RD. On 9th July, he was diagnosed as a horseshoe tear refuse treatment, and it has progressed to RD, and then we treated it and shown it to the results. Then pre-treatment, post-treatments are very important. This was a bilateral subclinical RD case, which after buckling, you can see that this was a doctor patient. This was a huge choroidal detachment. In a single picture, you won't get such types of a big panoramic view in otherwise in a routine cameras. Here also you can see the counseling is very important in cases of nowadays, in cases of retinal detachment cases, as well as the injection cases where the patients are paying huge amount of money and they expect some results, and seeing is believing is the dictum nowadays. So you can show this pre-treatment and post-treatment photographs. This was also another case of pre-treatment and post-treatment surgery. This was a pre-treatment. This was another case of pre-treatment and post-surgery and pre-surgery. This is another, just a second. This was a drop nucleus case. After surgery, you can do the counseling of the patient as well as the referral doctor. This was a huge giant retinal tear with PVR case. After surgery, you know that this is the result, and this otherwise, if you don't have the picture, you also do not remember what was the beginning point. So this is important for this purpose, and this is a sequential thing that normal course of the disease you can see in a ERM usually you observe, but as disease progresses, you do the surgery and show it to the patient that this is a recovery. This is again in cases of ROP also post treatment. You can see that the peripheral retina is well ablated long back. And these are the cases where you can take the pictures on Daytona also, the ultrawide field imaging of the ROP also, and we are taking it. This is a falciform fold in ROP case, and this is a well treated. Once the counseling is done, the patients are happy and relatives are also happy and they are well convinced. And then there are situations where you are also stuck sometimes, where you don't know what is the diagnosis and what is the approach to this type of cases. Then such types of panoramic pictures you can refer to or send to the experts or your teachers and take their guidance accordingly. And this is possible and only with this picture, single click. Otherwise, you keep on explaining, they will not get what exactly you want to tell. And taking the ultra wide is not the thing. It is an habit or a passion. You can take, say, with simple your photograph camera also or a mobile also, and make habit of taking the pictures. And one day you will also like to do the ultra wide field imaging. Thank you very much.
Thank you very much for showing us an atlas of all the various retinal diseases. Just one question, sir, which is the device that you are using?
I'm using this Optos Daytona, which is giving the fundus for ultrawide fundus photography as well as fundus autofluorescence of almost 200 degrees.
Manoj,
Yes,
this
madam.
Daytona is much smaller than the earlier Optos
Yes.
wide field imaging machine, right?
Yes, it is a very useful and handy, and you can screen almost every patient. So Daytona otherwise is having angiography as well as ICG facility. This facility is not with the Daytona.
Okay, and any kind of, is there a learning curve to this or
Nothing. This is just as anyone.
like a fundus
I
camera?
am saying anyone in your OPD, even patient's attendant can also take a photograph. Within 0.4 seconds, you get a panoramic view through an undilated pupil.
All right. And is there any kind of special
Manoj,
positioning
just
that
I
you
have one question.
I am not kidding. It is confused with your both of the wise. One at a time, please, madam.
Manoj, I
Yes.
wanted to ask you is that in this children, as in the older machine, that you had to use the flying baby position
Yes.
for
Yes.
positions.
Same
You have
here
to do the
also.
same thing here also?
Same thing also. We have to take out the cover and open the camera fully and adjust the flying baby according to the picture. And
Okay.
you get it is a little bit tricky. Takes some time because baby do not fixate it properly.
Okay.
So sometimes you won't get picture, but once in a while you get a good picture also. Sir.
One question before we
Yes,
close
sir.
up your talk. Can we somewhere crop this lid's shadow?
Yes, it can be.
Probably that's the only thing which I had this issue, that
Yes.
whenever that lid shadow, it distorts the whole thing. So if you
Yes,
can crop it, probably that's the best thing what you can have.
Yes, whenever you want such types of thing, there are two things. You have to use the lid speculum, which are having plates. Okay, and otherwise you can use the sticking, which stickings use come with every drape of the surgery.
Yes.
Those don't throw away the sticking. Use it in the OPD.
Wonderful.
Attach it
Good
to the
idea.
lids.
I think
Yes.
we should shift to the next talk. Karobi, can you?
Yes.
Manoj, I have
Thank
one
you.
question. Manoj, please,
Yes, sir.
please.
Yes. Yes.
Manoj, I have one question. Can we see aura with this? Or can
aura,
we
it is not
dynamic,
just, it is
dynamic fundus photography?
it is possible if you shift the focus little bit. You can change it to the right side, left side, upside or downside. Then aura is also seen. You have seen that the dialysis was seen. Means aura is almost seen in that trauma cases.
And can we do angiography also?
Angiography, if you photograph this Optos model, Daytona won't give you the angiography.
But you said you could do ICG also with it, no?
With the not with the Daytona, with the Optos it is
With the
possible,
Optos,
or you can have a ultrawide field Heidelberg spectralis.
Oh, so this is only for imaging and photography.
Imaging, but this is a tremendous useful, sir, madam.
Yes.
Here you can see that this is a dialysis which is captured.
Yes.
And without any effort. Here also you can see the up to periphery. You can see the choriotentis clepidorhabis clear.
We are extending the time.
Yes, thank you very much. Thank you everyone for giving me the
Manoj.
time.
That was a brilliant talk and lovely photographs.
Excellent talk.
Thank you. I'm exiting my screen.
Thank you, Manoj.
Thank you very much, sir.
Excellent talk, Manoj. Thank you.
Yes.
Yes. Good morning, everybody.
Good morning.
Good morning.
Shall we go over to Prashant, if you're ready?
To me?
Yeah.
I'm ready, but then there are other speakers. I can.
See, Saili is not there.
Okay.
And Chaitra has gone for a parallel meeting.
Okay. Shall I in continuation take this video angiography?
Yeah, please do that.
Okay. So that's something because it is related to retinal
Related.
imaging. So let me just take you through the journey of angiography. We all know that angiography is a very important tool in the hands of us retina people to understand the flow patterns inside the retina. So just I'll take you quickly through the machine which can give you this video angiography. We are using this IDON. It has got ultra high resolution. It has got wide field, and it is automatically, it takes the pictures and it can do multimodality. Now, just I'll give you some pictures and I'll give you some comparison. Don't think that I am selling any machine. It's got a high resolution. This image itself tells you what it is. It is wide field, and in ultra high resolution, you can actually go into the details about the structure or the details about the corneal textures, the retinal textures. It also, in comparison between our top one, I don't know personal interest in this. It has wide field. It can take one picture of 60 degrees as compared to 45 degrees, which are used to. And this is just the comparison, the same patient. And it has also an automatic fluorescein angiography, which can be done. Now, that is where I want to emphasize my today's talk, that once you have this kind of images, it tells you how quality image can change the perceptions. This is a color image, then this is a red-free image, the IR image, the AF image, and the FFA image, all of a very, very high quality and high resolution. So that is where the camera comes into picture.
Can I interrupt, Prashant? We are not seeing your screen.
Are you not? Oh, sorry. I'll do that.
You have to share your screen.
Okay. Sorry for this. I don't know. This is the problem with this.
Share screen, the green button, just press on that.
1 second. Let me escape, because then only I can come. So that is the problem with this, Let me go back and, oh yes, this is the share screen.
Yes, and then select your presentation from the desktop.
Where do I have my presentation? ये वाला है, इसको share करना है, मुझे करना है.
Just first open your presentation.
Yes, now we can
One
see
second.
it.
Now you can see that?
Yes, we can see. Now just make it full screen.
Okay, I'll do that. Sorry for
Yeah,
this.
we can see now.
Can you go back to
Can
the
you go back? I'll go back. Yes, I'll start from the beginning. Yes.
Right. Thank you.
And is it okay?
Very fine.
Yes,
Okay.
it is.
So this is just to take you through some quality images, which I have been able to do it with this. 1 second, I'll shift this thing away. So you have this machine which gives you an ultra high resolution. It also gives you the, It gives you the wide field images. It also gives you automatically, it captures the image. It has got multimodality advantages. Now, let me take you through few images to make you understand what is this ultra high resolution. When you see the image like this, it really gives you a great idea about what is the retinal texture, the retinal, whatever lesions which you see on the retina. And this is to show you a few microaneurysms, a little cluster microaneurysms very close to the fovea. Now, this is just a comparison, no financial interest between the two. And the wide field is, it gives you in one shot 60 degrees, which is very good. Most of the time we require this area. And it's just a comparison between the same patient with two machines. Now, most important, which I want to talk today, is the automatically it can take a video angiography, which is where it edges over the other machines. Now, this is, it also has various color options. Like you can take color images, you can take RF image, you can take IR image, and you can also have an AF and a fluorescein angiography. This all multimodality is inbuilt into this machine. So that is probably one of the only machine which I found has so many features together. Now, this is where the highest resolution camera is in the market, as I understand, because I have seen these are the pictures I used to see, and now I'm seeing with this. And you can see as clear as this, where the picture becomes so clear, it makes you understand the disease process much better. Now it works with a 2.5 millimeter pupil. Now that's where it helps, because your junior or your assistant can create these images and send it to you on your laptops or on your desktops. Now automatically you can mosaic a wide field. I cannot compare with Manoj's pictures, but then I think this is reasonably good for the cost, which is less than half the cost of what Manoj paid for Daytona. And this is 150 degrees, and which is more than enough. All modalities, including FFA image, can be done on this. This is just to show you one video angiogram. Now here we see a classic case of a central serous, and you see, now you have seen, this is what we are used to seeing, a dot leakage. Now let me take you through this is dot leakage increasing. Now suppose you go to the video angiography now. See, video angiography has started, you have injected, and the pictures start coming. Now you've seen the arterial phase. Still, now you can start seeing a hyper spot there, and gradually the spot is increasing, and everything is, see, I always feel that this is what every surgeon should see before deciding the treatment. But most of the time we see still images, and we see images post when it has been taken by your junior or somebody. Now here the 7 seconds and everything is over. Now you're seeing the choroidal phase going. So you know as to how much is the leakage. Now, this is another case. Now, when I saw this case, I was a little perplexed that this is a diabetic retinopathy. But I found that if you compare the upper retina and the lower retina, you find there is a difference in the extent of damage into the retina. But when I saw that, I said, well, angiography was done. It was a diabetic retinopathy with exudates near between the disc and the macula. There are flame hemorrhages also. There were dot hemorrhages also. Now, if I take you, this is the picture which I saw first, which gave me enough idea as to, yes, there are dropouts. There are areas which require heavy lasers, and there are areas which require treatment. But again, I found that there is a difference between the two. The upper retina was seemingly better, though there were lesions, but they are better than the lower retina. And then the video angiography gave me a clue as to why it is happening. Now, if you see the video angiogram, you will find that there is a definite difference in the circulatory pattern. I'll show you. Now, this is where you just keep watching this video angiogram. Now, you see the artery starts filling, the upper one starts filling earlier than the lower one. Upper one fills better than the lower one. Now, all these features suggest that there is a arterial blockade also. Now, this is where the difference starts, that you have to start searching whether this is behind, how much behind, and is it at the disc level or is it behind that? So this is where this thing is important, that sometimes watching a video angiogram is as if you are doing yourself. Though it has been done by a junior or by somebody, you can do that. So that's the advantage of this multimodality retinal imaging. It's easier and better quality, and it optimizes your patient flow. That's why it's a small presentation to make you emphasize what is the advantages of video angiography. Thank you so much. I think you can go ahead with the next talk now. I'll stop sharing my screen now.
Yeah,
You
sir.
have another
These
talk.
are-
Any questions on this?
No, you have another talk, no, Prashant,
I have one more talk.
on microperimetry. Okay. Prashant,
You
what I
want me
wanted to
you
say.
want me to do that also?
No, we'll just ask you one or two questions on this.
Okay, then that's fine.
I said that, see, the thing is that Daytona and your IDON, they are relatively very expensive machines. Do you feel
IDON is not.
IDON is not?
No, it is less than 50% of the cost.
Okay. If I may just ask, what is the cost of IDON?
Around 25
25
lakhs.
lakhs. Okay.
This is the cost.
Pardon?
Lakhs only.
Manoj, for 25 lakhs.
25 lakhs. Okay.
1,000, I can have, each room has one IDON.
Yes.
It's a beautiful machine.
Not 1,000.
Prashant, as
Yeah.
Manoj also said, that in his Daytona, he doesn't have much of a learning curve. It's very simple.
It's very easy in this.
Even this is as simple.
Very, very easy. It is much easier than Daytona. Daytona has
Yeah.
sometimes, you have to focus. Here, it is like a fundus camera. It's a tiny device, as I said. It is half the size of Daytona, half the cost of Daytona. I mean, less than half the cost of Daytona. And, all these images can be transported on your desk. So you don't have to worry about, see what happens, Karobi, is that when you say, oh, I missed this particular phase, in a video angiography, you don't miss anything, because right from the injection to the end, what you want, everything is there, and then what you delete and whatever. So that's why I feel that it is a
Sir,
good alternate for a poor person like me.
Actually, the thing is that here you have been able to demonstrate the fluorescein angiogram from
Differential polyphenols.
right, so which is not possible with the Daytona, as
Correct.
Manoj told us. But the advantage of that is that it gives a 200 degrees view, which is like a superb kind of view.
This is
right?
180 degrees. I
180
went to
degrees, yes.
I think, Karobi, it is a hype. All these machines which are giving 200 degrees, how many times those 200 degrees have helped you? It is more for teaching. It's more for juniors. But, every institution is not a teaching institution.
Yes.
And they don't afford this.
Have you tried
Has
in
the
pediatric
ultra-wide field
pediatric
made any changes in the way you treat your patients?
It gives you more
Only for
insight. It
documentation.
gives you insight into the information. Sometimes this wide angle angiography gives me an information as to how much I should tell the patient what all treatment he is going to require. Is it only the anti-VEGFs, or is it the laser? Is it how much laser? Because see, ultimately, if you show them this image and post-operative, post-anti-VEGF or post anything, you show them the follow-ups. And the patient understand. If they show him small images and a larger image, patient understand. Because see, I have one large image in my clinic, which is where I tell the patient, this is what you have. But that I cannot have individual, that is a general image, showing all the diabetic retinopathy changes and all those things. But here I can immediately, patient sits on that 2.5 millimeter pupil. Now that is probably the best what you can expect. This image is coming from a 2.5 millimeter. Manoj will agree, because Manoj is a rich person. He's a rich guy.
Nothing rich.
He always.
I agree with you.
nothing rich or poor.
The best thing about
And
Manoj is
Prashant, you're not far behind.
the thing is that, madam,
at half the cost. That is the advantage of Manoj.
that is very important. But madam, what happens over a period of time in a practice, you don't have a teacher to teach. These are the machines which gives us the self-evaluation and self-criticism also. You learn so many things, how many things you miss day-to-day practice, and this machine will tell you that you had missed this thing and how you were managing years together without knowing this fact.
It's a learning.
That's why these are also teachers also, not only to teach the patients and students, but machines teaches you several times.
Yes.
I had a question to both of you. See, the thing is that in everybody's practice, we've all had our share of tricky patients and testy patients who sort of act little irritative, or some kind of medical legal issues. Do you feel that this instrument has helped you in any way?
Yes,
in such
lots.
kind of patients?
See, these are the cases which is very common.
We can record this and we can say that, yes, I have recorded. It's not that you can tell tomorrow that I was not knowing this and all that. Yes, it helps you to learn, and it helps you to get out of tricky situations.
See, when we come into the medical practice or retina practice, our job was to telling the same thing repeatedly, and about the prognosis and outcome. Now he sees one picture and he is kept quiet.
Correct. I think we should now go to the next talk, because we have been messaged that there are 2 more talks there. If you want me to finish the microperimetry,
finish your microperimetry.
Okay, I'll do that, so that will be a quick thing.
If there is time, we'll take questions at the end.
Okay, 1 second.
Sir, one question only. Have you tried in pediatric patients?
No, pediatric
patients.
See, it's difficult because 2.5 millimeter pupil, you need patient's cooperation to focus. So it's not possible.
So there, Manoj scores an advantage over you.
Yes, Manoj has an advantage over me.
Thank you. Daytona has advantage, not me. I'm not
Okay, so I will go to my next talk, which is
microperimetry.
Microperimetry. Where am I? The problem here is, yes, here. Can you see my screen now? I'll share my screen.
See you.
You can see me, so I'll go there. I have to
go to the green button, share screen.
I have share.
Yes, now we can see it.
So you can see my OCT SLO. Yes, that's it.
Yes.
Fine.
Just
So you
make
can
it
see
full
my
size,
screen.
please.
I can go to the full screen.
Full screen, yes.
So this is something which again is a very something very close to my heart. When I got this machine, I didn't know what to do with it, and gradually I realized that this is something which is very, very important for understanding the diseases and its function. If you have a lesion like this and you see you don't know what is happening into this lesion, and you want to know whether what is the functional thing, and for which this machine gives you the idea as to what is the exact function of that small area. Now, I am using a spectral OCT, which has got a inbuilt microperimeter, and it is given to me free of charge, so I don't have to pay for it. And it gives me localized perimetry function of the retina at that particular spot, which I want. It gives me fundus image, which is generated simultaneously, and you can correlate between the fundus image and the sensitivity of the retina. Now, that is probably one of the best thing which can happen. This is my OCT machine. Machine setup is very simple. You choose an automated pattern. You can decide whichever pattern you want. I'm going quickly because I want to go to the diseases. And you decide the duration of the stimulus, interval between the stimulus, what side of Goldman's this thing you want to use. And then you can, machine setup is over and patient setup, and you can start it. Auto align the patient, auto focus, and start it. Now, how do we know that exactly the same place is there? That is done by analyzing the fundus, and microperimetry starts automatically. When you prime the patient, software will select a vascular structure close to the region of the testing what you want to do, and the selected structure will be used. Now here it is, the user can select the location or the machine selects. There is a tracker which tracks the vessel, and once it has tracked the vessel, it makes a marker. So when you are testing, you can always see that the marker will always point at that particular vessel at a particular spot. That gives you the specificity and exactness of the diseases. Start the test, and if you're repeating the test, there is a retest which will give you the comparison also. And when it is completed, it can be compared with any of the previous MP macroperimetry exams you have performed on the same eye, the same patient. Now here I'll just give you exam number 1, exam second time you examined, and you can compare from the database as to what it is. Now here you can see that the first exam and the second exam, you have differences in the decibel values of the retina. It gives you an idea as whether the disease is progressing, or it is worsening, or it is improving. All this can be done because this is an exact thing. Again, to tell the patient, this was what you were, this is what you are today, is the advantage of this. So here, one example, we had a case where we had multimodal, because of OCT along attached it. You have a fundus image, you have pictures, and you have an OCT image. Now here we see that there was a large thing, and all those the MP values are 0, 0, 1, 2, or 4. So a patient has lost a lot of central vision, and you treat the patient. The patient's hemorrhages have cleared, but hemorrhages being there also, you are seeing the improvement in vision. Patient is happy. So this is the biggest advantage of microperimetry, which you should practice. It's a very easy procedure if you have inbuilt microperimetry with it. You have this comparison between a pre-treatment and a post-treatment. You find that the values are changing. These values tell you, and there is a differential map also, pre and post treatment. I think this is a great tool to explain to the patient. I had a patient, this child came to me, 12 years old, and his was blind. Parents were really absolutely devastated that their 12 years old child is blind. I did a perimetry in spite of knowing that nothing is going to come out of it. But here I found one decibel value of 10. Now, this I showed it to the parents. I said that your child is not blind totally. He still has some vision, spark of vision there. And the patient, I really made their parents very happy. And probably this is one thing which I have used and I have found it to be good. You have lesions like a choroidal nevus. You want to know whether this nevus is going to increase, whether you need to do something. And you can know this exactly by calculating the changes in the microperimetric value. MP values will change if the lesion is increasing. Now here again, you are seeing that threshold sensitivity over cystic spaces are worse. So this is where you can find it out. In age-related macular degeneration, it gives you lesser values over the degenerated retina. The thin retina gives you lesser value. And here again, few cases I'll go through that this is an age-related macular degeneration where we have done microperimetry. We have found it out that the values have gone down. The patient can be explained that, see, you're losing vision. You still have vision, but you are losing further. And gradually, this is where, sometimes a patient with post-traumatic scotomas, we can show the patient that you have lost RP cells in this particular zone. And that's why you are, though you have 6/6 vision, you have to keep a watch on it. You may develop something in after some time. So this is where post-traumatic scotomas can be mapped. Now here we are showing improvements after treatment. This is where it has helped me a lot, that exact values are given to the patient once we have done this, and we can compare November to December. The values have increased. That means there is an improvement over time of 8 decibels. Now this is what is very important. You are quantifying your improvement. There is a difference map which has been given between November and December. Again find the thickness has gone down over time, again from January to May. So there is no improvement. The patient, there is no improvement, and that is where probably you can tell the patient that I have to change the treatment, I have to change the molecule, or whatever you can explain to the patient. So no improvement also is a big tool to tell the patient what is the difference, what is the important. So we have a lot of patients who had no improvement and we had shifted to the molecules. So microperimetry basically tests visual functions at precise retinal locations. SLO is used to track the retina and patient fixation. Retinal sensitivity is tested at discrete locations. It fuses the images of OCT, perimetry, and retinal thickness map. So this is what is important in this particular microperimetry, which we have been using from last couple of years. And sometimes you have found out that when you do an OCT, the inner layer and the outer layer changes. We find that if the layers are inner layer changes, the damage is much more. Thank you so much. Any questions on this?
Excellent talk, sir. I have one question.
Sure.
Have you tried in macular hole prognostication?
Yes, that is one thing which unfortunately, time was very short and I had to finish within time. Macular hole, especially the surrounding of macular hole, how much vision has been lost depends on the thickness or the cystic changes in the edge of the macular hole. So that, and after surgery, it's a wonderful question that Santosh, after surgery, I found that though the hole is not closed totally, it is a flattening of the thickening, a thickness has gone down, the vision is improved. I tell the patient, see, I have done this. You have, though you may say you have not improved, but you have tested, this is your test, it's your figures, and you are saying that now, because when you press it, it checks, it's like a perimeter. It values it. So the value is created by the patient. So probably in macular hole also, I have series, I have not yet, included into my talk, but I think Chaitra would have done a lot of these things because their centers keep doing a lot of new things. But I have found this to be a very good, useful tool. It can be done by your juniors or by your attendants also. It's like a perimeter. You to prime the patient, and comparison, most important. Next time when you take this patient, you say retest, it will start the test from the same place because it already has a tracker in place. So you don't have to prime the patient again. Yes. Chaitra,
wonderful.
Yeah, I'll give you an anecdote that I went to Arvind when Dr. Kim was there and my son was taking training there. And Dr. Kim told me that, can you talk to my colleagues, my juniors, that what is the useful, because they had perimeter lying there, not used. I'm sorry, I'm revealing this, but then they have started using it. My son was there and he said, now they are also realized the value of a test, because you buy a machine and you don't use it, that doesn't make sense.
Prashant, I had a question for you.
Sure,
I wanted to know that, okay, you record that there is 8 decibels over here, or there's an improvement in the decibel value, but I would like to know what is the correlation of the decibel value with the actual visual acuity improvement in a child when you show improvements.
It is improvement means quality vision improves. Let me tell you. Rarely, of course, when the vision had gone down to 6/60 and then the vision is improved, that's different. That automatically you understand. But if you improve on the decibel value, patient can perceive light better and he starts recognizing the figures. I don't say that unless your value is about 18 or 16 and all that, when it becomes normal, but there is a definite perception change. And it is also, as you said, medico-legally, yes, we have done something and we have shown the results. So you are safe as far as that is concerned. You didn't do some surgeries just for the heck of it. Sometimes it happens that 660 visions remain 660 more post-macular hole surgery. Then the patient says, what did I gain? So I said that, hey, fine, I know that you have lost the central vision, but you have regained some part of it and it's going to remain with you. So probably, yes, that is something which is more of our satisfaction that we have done a good job.
But is there any table where you say that, okay, if the person has so many decibels over here, he's going to have this much amount of vision, maybe 660 or 630?
No, it's
Is there
no,
anything
because
like
it's a
that?
generalized vision. It's not like not like one 8 decibel value is some spots which were -8, they became 0, or those were 2, they became 10. So that is the decibel change of that particular spot. See, in macroperimetry, you are checked, tracking that whole area of retina which you selected. So it's like a perimetry which you keep doing all the spots. Patient keeps responding by pressing a button. That's it. If he sees it, he presses. If he sees it, then the value goes down or up. So probably that doesn't correlate with exact figures of 2020 or 20, whatever. But it is helpful, and it is easily, I don't know whether now they don't give with OCT machine, but now you have to buy a separate microperimetry.
Again,
Yeah.
this machine can be used in pediatric patients. Suppose there's a patient.
No, a pediatric patient, very different. See, pediatric patients need an absolutely different assessment, and you do need, because there are more of perceptions. When we tell the patient, I feel you're losing vision. And, nowadays we are talking about this, new molecules and all that. And when do you change and when do you give another shot? I think microperimetry tells you the lesion may be visually not changing, but if microperimetry is worsening, I can tell the patient, you do need a second shot, or do you need a boosting shot? Now that is where microperimetry is absolutely wonderful. That we are seeing lesion, as far as our eyes are concerned, we don't see there is any change. But once we see that the microperimetry is worsening, I can tell the patient, okay, fine, you can wait for some time, but this is worsening. And when he sees 2 visits, that worsening is more, he comes back to you for the treatment.
Okay. Let's go over to the next speaker.
Chaitra, yes.
None other than Chaitra. She's back from her other meeting. Chaitra will talk to us about pediatric retinal imaging, which is her main forte.
I know, that's why I spoke before. Otherwise, nobody will listen. Nobody will listen to me.
Sorry.
Welcome
Sorry
to this seminar, and you're always great in your presentation. Go ahead.
Thank you so much, sir. Thanks, Karobi. I'm so glad you're here. So in case I'm not around, I'm sure you can even take it forward because you're so good at this. I'll be speaking on pediatric retinal imaging. I have no financial disclosures. Right. So to highlight, we'll be talking about ultra wide field imaging. We'll be talking about fundus angiography, STOCT in infants, and what's new in that, Octa, the new tool, and also software analysis and AI. So wide field retinal imaging, I think, has now become part of our practice. It's so easy to explain to the patient, for us to visualize the peripheral retina in uncooperative patients or not dilating, and even in children, young children, they're so much more cooperative for a one-time imaging using wide field. So this is the literature that was published, quite some time ago. It was a fast-track paper which spoke about the use of optos actually in these children. They used the, flying baby position here, as you can see, that is put up there, and they were able to get fairly good images of the retina. So especially of the peripheral retina with fewer number of images of the quadrant, more panoramic view that you get here. So this is another patient here, FEVR, where you can see temporal traction very well. The stalk can be seen extending up to the ora, and nasally as well, persistent avascular retina can be seen very well, which gives us an indication for treatment. So this is, again, the optos image here. This is the fellow eye showing avascularity 360 degrees, and it shows NVs also, again, indicating the requirement for treatment. So this is the angiography as well. This is the role of the fundus fluorescence angiography in the management. So let us look at these some images of this. This is a baby post Avastin and then laser done in another center. Came to us for opinion now. Is about 9 months old. You think that it looks a little quiescent, the disease, despite not adequate laser. But on closer look on the image itself, you can see some amount of fibrosis in the upper temporal quadrant. You can see a closer up look here. You can see the fibrosis there. The fellow eye too looks quite okay, seems to be doing well with regards to the stage and the disease there. And however, when we do the angio, this was done on the REDCam3, tells us another story. You can see active neovascularization even 9 months after the initial injection, and a large anterior area that is not only ischemic but also requires treatment soon enough. And that was also seen in the other fellow eye. So it is only after careful supplemental laser and fill-in the other sparsely treated areas that we were able to bring the disease to stability, and it turns quiet, and the NV also regresses. So going on to ST-OCT in infants, so this is the international nomenclature for OCT now that we use for adult retina. We are very familiar with this now. We use these terminologies. We did have switch over time, but now we're all used to using ID and EZ now. But the OCT in infants is different, and a premature infant is not born with all the layers. So here is a 37 corrected PMA baby showing OPL straightened. There is persistence of the IRL. There is ELM that is seen, but no foveal tenting because the cones are not tall enough. The EZ and the RP are there, but there's no interdigitating zone. You can't see that. Infants do not have all the layers. When do they develop, and what influence do they have on vision is therefore very, very important. So this was a paper that was published where we looked at the foveal layer morphology detected on ST-OCT, and we correlated with visual acuity in infants in their first year of life. What we saw here was that inner retinal fusion or maturation was the most important event that correlates with better visual acuity throughout the first year. And between 9 and 12 months PMA, the completion of the EZ at the foveal center positively influenced visual acuity. So again, in this, we checked all these children at 3 months of age, which did show some amount of improvement. So we can also detect subclinical pathology. So this is another paper where we looked at macular changes in early ROP on ST-OCT. It showed that 29% of babies with spontaneously regressed ROP have some amount of foveal edema. So we categorize these macular changes that resembled edema into pattern A and B. So this is pattern A, where you see a dome-shaped elevation similar to an adult CME, intraretinal cystic spaces, vertically high the reflective septae are there, disruption of the foveal center. Then you also see the pattern B here, where again the foveal depression is relatively preserved, but you see intraretinal cystic spaces. You see fewer and lesser reflective septae and confluent or near-confluent vacuolated spaces. So this is the pattern A before and after resolution, and pattern B again. So pattern A had complete disruption of the foveal dip and a much larger CRT. Here, despite this edema showing spontaneous regression by 52 corrected age, we found that infants had poorer visual acuity at the end of 1 year when compared to age-matched cohort without edema and without ROP. So this definitely has a bearing on the visual acuity outcome. So this was another paper with Down syndrome infants. They have abnormal foveal morphology and persistence of the inner retinal layers as well. Here again, we did a correlation with the vision. This is another paper where we presented the expanding spectrum of ST-OCT in pediatric patients. And we could show that the value of a handheld device in these patients is extremely important in picking up a lot of vision-threatening conditions which can probably treat on time. So this is the number of patients that we saw. Now going on to OCTA in infants, it is a difficult imaging technique in infants because it takes a little bit of time to image. They need to be a little more cooperative. So we have been doing these studies where we've been looking at infants with unexplained vision loss. Sometimes we want to image the macula. So this is monitoring the neovasculation of an APROP using OCTA. This is one of the first papers that was published using OCTA in one of the youngest subjects. So this is an APROP post laser showing a flat NV, and the FFA shows avascular retina and neovascularization. On the OCT itself, you can see superficially neovascularization. But if you go on to the OCTA, you will see deep, the NV is in the superficial layer, and the deep layer shows shadows indicating flow. And the outer layer shows the flow, and the choroidal layer or the chorocapillary shows the shadow aspect. So selective laser was done here, and post laser, you can see that the neovascularization is now regressing, and also it has gone into the deeper layers, and that was also now returning back to normal. So it is not only superficial. What we try to show here is that the neovascularization is actually a complex which can go into the deeper layers. So there's few other patients that we've been able to study, 44 Indian children aged between 5 to 10, premature low birth weight, about 25 with ROP and 19 control. We use the Avanti 3x3 and superficial DCP, and we used ImageJ as an to analyze these images. So what is the difference between normal and abnormal? You can see the round reticular layer here, whereas it's irregular, broken, and crossing in the abnormal. So what we found here is, despite normal appearing fovea clinically, you can not necessarily assume that the vascular plexus is normal. Even spontaneously resolved ROP had foveal changes. The capillary density was reduced in ROP, and DCP may be relatively preserved compared to the SC. So this I will quickly brush through. It is now actually not really much used. We have newer software, so I'm just brushing through these slides. It helps in subclinical detection, non-invasive, it's quick imaging in an uncooperative child, and handheld devices, especially useful for supine examination, and it has helped us understanding the disease spectrum much better and manage our patients. So these are some of the images that we're using, imaging tools that we're using. Thank you so much.
Thank you so much, Chaitra. It was wonderful. I just want to know how much time it takes, and do you sedate the child or something?
No, sir. None of them. Only time we probably require sedation is when we are doing angio in the OT. Even then, you know, it again depends on the age of the child. Not necessary. None of the OPD based we use sedation.
Okay, so even when you're getting such wonderful images of octa and all that, without any movement, the patient is not moving at all.
It's difficult, sir. It's difficult. So it's especially octa is tough. Optos is relatively
especially
easy.
I was interested in octa.
Yes.
Because that
Octa
gives you
is tough.
a lot of information, and it decides the treatment modalities also. Wonderful, great job, and then keep doing.
Chaitra,
Yes.
if you could just detail out, close that door, please. If you could just detail how you all manage to do it in these children, like what are the special precautions that you take, or the special kind of arrangements that you make, you know, for seeing these patients, the octa in these patients?
Nothing specially, Karobi. It all depends on the age of the child. If the age of the child and the cooperativeness is pretty good, the child just sits like anything else, because we don't have a handheld octa. We're using our Avanti machine. The child is positioned there. The reason why we don't have a very, very large cohort, you know, unlike for other imaging devices, is because it's a difficult examination in the children. Even the slightest movement, we don't get very good images. So it's a routine like how we image adults. Only when children cannot sit, they either seated on a parent, or we use the flying baby position.
And you use a speculum as well?
Yes. Sometimes, not for all patients, again, only in uncooperative patients.
You feel the handheld device gives you lesser resolution as compared to the normal when the patient is sitting in front of the machine?
A handheld, which device? The octa we don't have.
No, even the fundus imaging and all that, what you do with for ROP.
No, sir. So handheld is only now.
Blurred and always, you know.
I think our technicians have been doing so many images. They're pretty good, sir. They get very good SCOCT images also.
You have dedicated technicians doing it. We hardly do.
Prashant, it is like this, no? The handheld devices require a little bit of learning, you know. I mean, there is a learning curve definitely to it. Whereas these machines, it's easier to do it. I mean, the thing is that, of course, if you have a machine which is photographing it in one shot, it's much easier than using a handheld device, because there you have to have that exact adjustment of the distance, then there should be no movement. There is a lot of adjustment which is required for that. And the same thing, you know, I mean, we didn't have recourse to a red cam, but we used to do it on the fundus camera, and there also it is like, you know, as easy as doing a fundus photograph. Of course, it's not wide field, but the thing is that there only the positioning of the patient was very important, where somebody trained had to hold the patient, had to hold the rump of the baby and the head and position it in front of this. And I used to always use my sugar pellet to.
I have started using it.
Oh, very good.
It's a beautiful thing. You have a string and you put it into the patient. The patient is very quiet. Yes, are we having the last talk, or we are not having that?
No, I don't think Saili is there.
Okay, so is there any other input? Let's decide, Chaitra. You know,
Chetra,
you have
one
every
question,
machine.
sir.
But I think we have to give a message that what is the best wide angle system a person can have at the lowest cost?
So that's a tough question, sir. Because, I'll tell you why. Because each center or each person's requirement is very different. But given the fact a lot of smartphones are giving very, very good,
I know, that's
wide
why.
angle. So I think any of the newer devices, smartphone based for a single practitioner with those wide angle lenses are more than adequate. Because see, it depends whether it is for documentation, whether it is for publication, whether it's for your presentation. So it's a very wide, question in the sense that, of course, because we're a large institute and our turnovers are much better, our ROI will therefore be good enough. We have gone in for the optos. But I think the Claris is good, the IDON is good for centers, which have a large.
I think Claris and IDON, they make up for whatever they lose in cost. Thank you so
One
much. I
last
think
question.
we are finishing in time.
Thank you.
Swapnesh?
One last question. One last question.
Last question, Santosh, then we
Yes,
close.
Santosh.
Do we have to dilate each and every child?
We
Is
have
it necessary?
we have to.
Yeah, so optos is not a requirement, sir. But if we dilate the patient, the image quality, the artifact is much, much lesser. But even in non-dilating pupils, even in K-Pro patients through optos, we've got extremely good images, at least up till the mid-peri. Recently, I got a K-Pro patient done. It's like, 2 or 3 millimeters, beautiful image.
Chetra, you have any senior citizen programs in your institute?
We
Thank you so much. It was just to stimulate you for your next talk. Thank you so much. I hope your daughters are doing great. Thank you so much.
all good, sir. Thank you.
Chaitra, I just wanted to ask you that you mentioned these two kind of patterns, how much of time does it take for resolution? 6 months or 1 year of the
We've
pattern?
seen 6 months to a year, Karobi, at least 6 months to a year. We've had a serial follow-up, and a lot of it we've even gone back and seen retrospectively. It takes 6 months to a year.
Okay.
But it does not translate into actually visual acuity. The rapidity of resolution does not correlate.
That message should go down, because basically everybody expects that you're treated and patient's vision should improve.
Thank you all the speakers for the wonderful session.
Thank you very much, everyone.
Thank you.
Thank you, Santosh, Karobi, especially to you. And it was a wonderful session. I learned a lot. Thank you.
So did I.
Thank you very much. Thank you.
Over to